Okay, I'll introduce our next speaker. Dr. Rachel Collins. She's a Consultant Paediatrician in General Paediatrics and Adolescent Medicine here at PCH. She has an interest in medical education. She's the Director of Paediatric Education at PCH and a Senior Lecturer in Paediatrics EWA. She also has interest in service improvement and improving the navigation of the health system for patients with complex chronic diseases. She's the clinical lead of the Child and Adolescent Health Service Transition Service and the Complex Transition Clinic, and also the medical lead of the Connect Care for Kids program. She also established and chaired the WA Health Youth Transition Network, and she's a founding member of the education group. That's a large anagram, so I'm just going to say it out loud. Planning and promoting adolescent and youth adult services. And she's the member of the Kids to Adults National Clinical Research Network. And she's a member of the RACP Adolescent and Youth Adult Medicine Committee. Rachel is originally from Northern Ireland. She trained in Manchester and Belfast before she moved to Perth. And between doing all of that, she also is raising 3 children. So please welcome Dr. Rachel Collins.
That doesn't leave much time to talk about anything else. My job is in general paediatrics along with Dr. Derek, but I also work in adolescent medicine and transition. So just wanted to talk a little bit about sort of youth health generally in the context of chronic disease, and then about transition to adult services. So for some of you who've got young kids, this might seem like it's a long way off, but youth health starts at around 12 years of age, up until the age of 24. So even for those of you who've got little toddlers, 10, 12 years isn't that far away. So just want to outline why is transition important, what is it, a little bit about normal adolescent development and the processes that young people go through, and what resources we can have here to help support. So transition, the key thing about this quote, which is the quote everybody uses to describe transition, is that it's purposeful and planned. So the fact that young people with chronic disease, that they're going to have lifelong, the fact that they're going to move across into adult services is inevitable, because obviously here at the Children's Hospital, we can't look after young people until they're in their 60s. The main key thing around transition is that it's planning for that movement across. So if we say to you that transition is going to be starting at around 12, 13 years of age, it doesn't mean you're moving to adult services at that age, it's just the planning. And transfer then is the name that you give to the point at which you actually move across to adult services. So generally that will happen at 18 years of age or the end of year 12, whichever is later. So it gives plenty of time from the age of 13 to the age of 18 to plan for moving across and which services you're going to go to, and I'll talk about that a little bit later. So the big orange arrow here is basically a gap in services. So from the moment you're born, particularly if you've got a diagnosis at birth, you'll be sort of well wrapped up by your obstetric team and your midwives and your child health nurses and GP at the beginning of your life, probably a general paediatrician, and as you go through life you're well looked after by the paediatric service. Then for some reason we've kind of got this big gap at the end of paediatric services that lots of patients can fall into, where they don't get linked up properly with adult services. Then once you're into the adult services and well established, there's a continuity through until the rest of your adult life and into geriatric and aged medicine. So why do we have this big gap here at a really important developmental stage for young people? And that's something that internationally is recognised to be a big deficiency that we need to fix. And it's what I'm trying to do in WA, but it's a quite big job. So we all know a little bit about being teenagers or being teenagers ourselves, and everybody has different experiences of what that's like. But the key things that teenagers need to do between the ages of 12 and 24 is basically to keep themselves healthy, to work out what they want to do with their lives long term, to work out what healthy behaviour is for them, to get ready for managing themselves within the adult health service, and to work out the complexities of that adult health service, and to work out what they need to manage for themselves and what needs to be sort of managed or coordinated for them. Adolescence is a time when you're physically developing, so your body's maturing, but you're also maturing as a person, and that's going to look different for everybody. There's going to be different developmental levels, there's going to be different personalities, and everybody's an individual, and that comes out more and more as you go through adolescence. And that's when you are going to want to try and push some boundaries and develop your independence and your autonomy, and that's completely normal. And sometimes people forget that young people with chronic disease who've been kind of wrapped up a little bit by parents or by their treating clinicians actually want that autonomy too, and they're going to want to push out a little bit and start making some decisions around their health care or what they do in their own lives, and that's absolutely normal. Developing normal relationships and taking some risks. So it's about learning how to take those risks within the context of your illness, and again we'll talk about that in a little while. And then also thinking about what their life looks like long term in terms of employment, families, education, etc. And this just sort of summarises it into a couple of points from the youth health policy, which basically is sort of saying that your health and well-being is a fundamental thing that needs to be stable and established, and then on top of that you build your personality, your autonomy and independence, and then you need to be able to establish yourself as an adult, and a healthy adult who's tied in well with the Adult Health Service, enabled to optimise your potential, and then that's important for the next generation that follows on afterwards. We all know that being an adolescent can be a time of risky business, so pushing those boundaries can involve things like smoking, drinking, drugs, just some risk-taking behaviours, doing things that your parents might not necessarily agree with. And for any young person, that's always a risk, and it's always about weighing up the kind of pros and cons of that behaviour. But for some young people with chronic disease, the risks can be much greater. So there's lots of evidence around this, none specifically for Noonan syndrome, but for lots of other chronic diseases, there is evidence that shows that sometimes there can be poorer health outcomes associated with risk-taking in adolescence. So to use diabetes as an example, if you've already got problems managing your blood sugar, if you go out drinking, the impact on your health would be greater than it would be for a young person who didn't have diabetes, for example. And that can be put into the context of any chronic illness, depending on how those features affect you. So we know that helping young people to bridge that gap from paediatric to adult health services is key in making sure that they keep their chronic health conditions stable during that time, and also to help support them during this time when they're going to be wanting to push away and get some independence, and also when they're going to be trying to do some risky things. We know that young people generally, so between the ages of 18 and 24, are generally at risk of suboptimal medical follow-up, and that can be because they do get lost in the transition from paediatrics to adult, but it can be that they feel that they've got better things they want to do with their lives than attending medical appointments. It's difficult for them because they're attending university or school or whatever and can't get to the appointments. It may be that they've got Superman syndrome and they feel like I'm, indestructible and I don't need to go to a medical appointment because that'll happen to that guy. It's never going to happen to me. Sometimes at this time, as a way of kind of expressing independence and autonomy, young people who've previously been really compliant with medication might suddenly think, actually, I'm just going to try not taking this and see what happens. And as an adult, that can be really hard because you know what the detrimental effects are down the line, but the young person has to have some autonomy over their management and experiment with their medication a little bit, and that can be very hard to get that balance right between being paternalistic and kind of imposing your will on them and letting them experiment a little bit with how they can push those boundaries. What we do know is that poor engagement with adult health services at the time of transition can lead to poor health outcomes lifelong, and that's why it's really important that we do address these issues now. And there's lots of research internationally that supports that. We know that transition should be done better throughout the world, and we're working at lots of different sites to try and work out how that should be done. And part of the way that we can do that best is by working with families and young people to find out what they need to optimise transition. So encouraging resilience and independence in young people themselves is really important, making sure that we talk from quite an early age, from 13 or 14, about their understanding of their medical condition, what the services are like in the adult world. They understand that they're not always going to come here. And a key part of that is having a relationship with a general practitioner. So even though if you've already got lots of medical appointments, it seems like another appointment to go to, actually establishing a really strong relationship with a general practitioner from an early age is really important, because often when you get to the adult health service, they're the ones who hold a lot of the information and the coordination of care in the way that general paediatricians do in the paediatric health service. And it also helps in terms of having some continuity in terms of the healthcare relationships that a young person has as they move across from peds to adults. And an important part of that is that it's not just the family GP who knows mum and dad and the other members of the family, but it's actually someone who has a relationship with the young person themselves. So even if that's just once every 6 months they kind of pop in, things are still going well, this was my last appointment with Dr. Derek, you know, no major dramas, but just building that relationship so that you get to know them can be really key when it comes to this age of sort of 18 to 24. So I won't bore you too much, because there's mostly families here, not so much clinicians, but this is around some of the barriers and the importance of transition from doctor to doctor. And basically it comes down to good clinical handover. So a lot of what we do as doctors is handing over information from one to another to make sure that there's continuity of care. And this is a big gap in that, where we very poorly hand over 16 to 18 years of a young person's life to a new team in a one-page letter where they're supposed to know what's happened for the last 18 years. And that's something that we really need to work on doing better. So that's one of the main reasons why transition planning is important, is because a lot of people don't realise that your medical notes don't go with you when you move across from paediatric to adult services. Or if you go from here to a private service or from here to your GP, your notes don't go with you, they stay at PCH. And so it's really important. Hopefully we'll have an electronic medical record someday in the future, but at the moment it's really important to try and collate some of that information kind of as you approach age of transfer. So keeping your clinic letters, using My Health Record if you're logged into it, and just keeping a track yourself of some of the key bits of information that you're going to need going forward. There are, for some young people who aren't living with their biological parents, there's also considerations around laws and guardianship and some of the legal practicalities of turning 18 as well, which may need to be considered. And there's also some financial implications. For example, some parts of the funding that you receive might change when you turn 18, and there are some consumables such as peg feeds and tube feeds and things like that that are funded in the paediatric health service that aren't funded in the adult health service. So as you get closer to the age of transfer, that's the kind of conversations that you need to be having with your clinicians around what is funded, what isn't, and what might need to be built into your NDIS plans and so on going forward, to make sure that you don't get gaps that cost you money. So just a little summary of some of the difference between paediatric and adult health services. Basically, we've got a bit of a reputation for being soft and cuddly and kind of wrapping ourselves around a little bit too much, and the adult health service has got a reputation of kind of closing the door in your face and not being very approachable, and I think the reality is somewhere in the middle. I think we can be tricky to pin down as well, and I think that adult health services are keen to engage as much as possible, but for some patients who may be going through a sort of rebellious phase and not engaging, in the paediatric service we would follow that up with repeated phone calls and offering appointments, whereas in the adult world, generally, if you miss an appointment, you don't get offered another appointment and you go to the back of the list. So some of those things, it's just really important for a young person to know that some of the kind of engagement that we offer in the paediatric service, we wouldn't necessarily, they wouldn't get necessarily in the adult service. And also that really important shift that in the paediatric health service, we often speak to parents rather than to the young person themselves, which isn't really what we should be doing. And in the adult world, it's the opposite. They'll speak to the young person and not to the parents, and some parents can find that shift quite difficult. And what we should be doing is involving both parent and young person all the way through that process so that everybody's informed and understands what's happening. So it seems simple. It is really not, believe me. I spend many hours of my week trying to unpick all of this. So the paediatric services often find it hard to let go. So when it gets to 18, nice people like Dr. Derek will probably say, oh, just come back and see me one more time. Oh, I haven't quite got the result of that. Just come back and see me one more time. And the next thing you know, your patient list is made up of 25-year-olds. So we are definitely guilty of doing that. And so much of my job is trying to educate people like myself and Dr. Derek about the importance of planning for this early so that when it does come time to move across, we're ready and the families are ready. And sometimes families find it hard if you've had a clinician for 18 years to move across, and that's very understandable, but it's important that we give you the feeling that that's been prepared and planned for rather than you suddenly turn 18 and we're like, oh, you're 18, I can't see you anymore, which is the way it's been happening up until now, which isn't good for anybody. Sometimes there are complexities around having an equivalent service. So, for example, there are general paediatricians. Here, there aren't really very many general physicians in the adult world, and there are certain sort of condition-specific specialties that we have here that there aren't in the adult world. And some of that is because there have been such developments in medicine over the past 15, 20 years that some young people who didn't actually survive into adulthood with particular conditions are now surviving for a long time and needing adult care, and those services haven't been built up over time to accommodate that. Navigating the public and private health services is an absolute nightmare. For example, with neurology, there are 3 neurology services in WA alone for tertiary care, 2 of which are at Charlie's, 1 of which is at Royal Perth, and working out which one's which and who goes where is troublesome in itself, and that's just one that's just for epilepsy, never mind all of the other things. So that's taking a bit of working out, and we are working on that and trying to navigate that system a lot better. I'll just skip past this. So specifically for Noonan syndrome, as you all know, there's multiple systems involved, as we've talked about today, and working out where you go for follow-up of each condition can be complicated in itself. And I'll try to work with Dr. Derek in terms of working out where are the best places. For some conditions, you have to go to a specialist centre. Say, for example, spinal is only at Royal Perth. For other conditions, it's based on postcode. So if it's something more general, your postcode will have a particular catchment to, say, Charlie's or FSH. For conditions where you don't need to be at a tertiary centre, you'll go to the centre closest to home. And for things that don't need to be seen in a hospital, then a GP helps to coordinate that care. So it can be quite complex if you fall into multiple of those groups. We would absolutely love it if everybody could just go across the road to Charlie's for everything and you already know the site, and it makes everything a lot easier. But unfortunately, that's just not the way it works. So I'll talk to you a little bit at the end about how we can help support navigating that. So the role for parents at this stage is really about helping your young person to develop the skills that they're going to need to navigate the healthcare system, and understanding a little bit of Medicare, of where the hospitals are, of the fact that they're not always going to be coming to PCH and some of those things, just helping them to have some decision making when it comes to their condition, going to the GP, talking to the GP by themselves, or whenever they're in appointments with their paediatricians, having a bit of time with parents out of the room so that the young person can talk freely to the doctor, so that they can talk about things that they might not want to talk about with you in the room, but also just so that they get used to that feeling of building rapport with their doctors and having a little bit of control over their own issues. Because sometimes the things that we as parents think are bothering our children are actually not what's bothering them at all, and we've got the completely wrong end of the stick. And we see that all the time where, you know, parents will say, oh, he's really worried about school or whatever, and then you speak to the young person by himself and he says, oh no, I'm really worried because my friend Joe doesn't want to play with me anymore, or whatever it is. It's often the parents don't know what's going on as much as they think they do, much as we would love to. And it's important for young people with chronic conditions to understand that they should be doing the things that everyone else is doing, but that they sometimes need to do that within the limitations of what's allowed by the condition, can't maybe push things just quite as far as some of their friends would, and understanding why that is and why that's important for them going forwards. Although I've mentioned a time frame a couple of times around transition being at around the age of 18, it's really important that we don't force that to happen until the clinicians are happy, families are happy, and the young person himself is happy and ready to do that. So it's a sliding time scale. It'll be around 18, but everybody needs to be ready. Otherwise, it's going to be an unsuccessful transfer to adult services, and nobody wants that. Young people themselves have given us lots of feedback in the youth health policy, and they've told us things like they want to be able to have a little bit of choice around, do they see a male or female? Can they go somewhere that's affordable? So if they need to go somewhere themselves without their parents, are they going to be able to afford it with their student allowance or whatever it is? They want things to be presented to them in easy to understand language, both verbally and written, and ideally online or digital, because they're much more savvy than we are. Making sure that it's actually easy to get to places is on a train line. So for example, Charlie's, the parents might say, we want you to go to Charlie's because it's close by, but the young person might say, actually, it's much handier for me to get a train to Royal Perth. I don't want to go to Charlie's. So the accessibility is really important. Having access to telehealth and telemedical services is a real priority for young people because they can just whip out their phone and have a consult with their doctor, whereas I think as slightly older people, we prefer that face-to-face contact with clinicians, but young people have actually said they really like the approach of using it. And in my general paediatric clinics, where I'm mostly dealing with parents, most of my appointments are face-to-face. In my adolescent medicine clinics, where I'm mostly dealing with young people, the vast majority of my appointments are via telehealth. And then there's some important things about showing gender equality, LGBTQI, just showing a general sense of inclusiveness wherever they're going. They also like to have long, flexible hours when they can go to places, because if they're at school or uni or whatever, they can't fit in that 8 to 5. A lot of them would like to have longer consultations so that they've got time to talk about some of the other issues that are affecting them. And many would like to have the opportunity to have walk-ins or unbooked appointments so that they can address things as they kind of come up. Access to Wi-Fi comes up again, and access to online content. But most of all, they basically just want to feel listened to. They want to feel that they've got a clinician that they can build rapport with. They want what they tell you as a clinician to be private and confidential, and we always say, whatever you tell me is just between you and me, unless you tell me that you're going to harm yourself or someone else is harming you, and it keeps that that communication safe for them. And whenever they move across to the adult health service, it is going to be overwhelming. And so if we can start to build some of those relationships with the adult clinicians prior to moving across, that just really takes away that sense of anxiety. And where possible, we'll try and have meetings or shared information, even a telehealth with some of the adult services to help bridge that gap when the time comes. So they just want to be respected, want to feel comfortable. They want to feel that you're trying to help. They want to make sure that they're well informed, and they want to make sure that whatever service they go to is a welcoming place. So this is what I'm working on with the adult health services, because if anybody's ever set foot in Charlie's or Royal Perth, a welcoming place is probably not the term you would use to describe them. And we're doing a lot of work around that to try and make that better. So from a transition service point of view, it's all around planning, and that's communication between the different teams, communications between families and clinicians, and communications between the paediatric and adult services and general practice. And the more everybody communicates with each other, the more effective transition and transfer is going to be. As I've said here, it's not done well in WA currently, and we're trying really hard to improve that. But we know that good transition, although it seems like a fluffy, airy-fairy subject, whenever you've got people like Dr. Gupta presenting about cardiac surgery and genetic treatments, this seems a bit like, oh, it's a bit fluffy and airy-fairy. But we know that good transition improves patient well-being and outcomes lifelong. And that, I can't stress enough how important that is. And there's lots of evidence in the literature to show that that's the case. So early engagement and information sharing through all the services and with general practice is essential. That's essentially what I've just said. So what can you do as families? Engage with a GP, talk to your treating doctors, Dr. Derek or whoever else, about transition planning when you get to around 12 or 13 years of age. We've got transition checklists in every clinic room. We did an audit last year, and I think out of 50 sets of notes, one of them had a completed transition checklist. So we're not doing a very good job of that. But if you guys can help to drive that and say, you know, I'm 12, I'm going to be moving across in a few years, can we just see where we're at with that? We'd be very happy to be jogged by you. My health record's a wee bit of a contentious subject. Some people are pro, some people aren't. Some people find it useful, some people don't, but it is one central way of kind of uploading all of your documents, so that's an option. Or keeping a file of your clinic letters and things. And it doesn't have to be every letter, because I know you go to many clinics over many years, but just the most recent ones or the really key ones. If it just says continue, carry on, you don't need to keep those, but the really key ones. Through the Complex Transition Service, we also have a complex care plan, which is essentially a Word document with different sections about what's important to you as a young person. So it's not necessarily about your medications and so on, but it might be about things that help to alleviate your stress, how you like to be referred to, how you like to do certain things. So all about you. We've got that here, so we can either give that to you from CAHS Transition Service or through Dr. Derek's clinic, and that's for you to own and populate yourself, and then you can print that off and take it to any ED or adult service that you go to, so you've got a bit of a summary. What can doctors do? So we haven't got a huge number of doctors, so Shani, I'll talk straight to you. Helping families to engage with primary care, we do it really badly. We should do it a lot better. Picking up the phone and saying, I've just seen Jamie in clinic today, this is what's going on, I just want you to keep an eye out for this. She was maybe a bit sad today, or I'm worried about her cardiac function, or whatever it is. AHEADS, I don't know if anybody has come across this before, but it's basically an acronym for adolescent health screening. So it stands for Home, Education, Activities, Drugs, Sexuality and Suicidality. And it's just a way of having a chat with young people around what's going on for them in their lives more broadly. Confidentiality is absolutely key. Always speak to a young person by themselves. If they're over the age of 12, you would not believe the things that come out when they get an opportunity to speak to someone by themselves. Doctors always think about transition in that age group, and there are lots of resources available that we can provide you with. Through the CAHS Transition Service specifically, we have a transition coordinator who can link you in with the different services in the different hospitals. We've also just managed to secure a transition coordinator at Charlie's, and we're working very hard at getting one at every adult site so that we'll be able to really smooth out that process, particularly for families like yourselves, where your young people are going to be going to multiple different specialists. So this will develop hopefully over the next few years in time for you guys to be able to utilise it, and we'll be able to help smooth some of those referrals and making sure that that transfer of information is a lot more seamless. These are some of the resources we've currently got available. So if you just go onto the CAHS website and type in transition, there's transition resources for parents, for young people with intellectual impairment, lots of different things that you can just have a look at, and we're building that web presence at the moment into a youth health hub where young people will be able to just scan a QR code and go onto a website that's got information about everything you could need, from employment to smoking to sexual health to whatever they might want to confidentially have a little look at. So as I said, transition starts at 13, and the most important thing is to continually harass Dr. Derek about transition until he sorts it out for you. Thank you very much.
Any questions at all? Well, you got off scot-free.
Excellent.
There you go. Thanks so much.